Thank you very much, KG. It is such a privilege to be able to speak to a distinguished crowd of experts who've been working and thinking a lot about not only the threats we've faced in the past, we face today, and how we can better face these threats in the future, since they will continually emerge and evolve over time. And we have a lot of lessons that we've learned through the years, and some might argue whether or not we've applied those lessons or captured those lessons sufficiently. So I'm looking forward to the discussion of the meeting for the next 2 days from this group, so we can not only spend a lot of time talking about the past, but spend more time talking about how we can bring things together in a cohesive way to be better prepared for the future. So as KG said, I am the Deputy Assistant Secretary for Preparedness Response. I work in the Office of the Assistant Secretary for Preparedness Response. And we spend a lot of time thinking about the future. Our mission in ASPR is to save lives and protect Americans from 21st century health security threats. And so we look at the threats not only as emerging threats from nature, but also threats that might be imposed upon us intentionally, either from an individual or a state actor, or different scientific accidents along the way. So we look at the wide range of microbial threats and how they might enter our world. And it was just this last year, in 2018, that a lot of work has gone on across the U.S. to put together, for the first time, a cohesive national biodefense strategy. I encourage you to look at the link and read that National Biodefense Strategy when you can. As you can see, there are 5 main goals in this National Biodefense Strategy that cover everything end to end, as you would expect from an emerging threat from nature as well. Enabling early awareness and risk assessment, all the way to countermeasures to mitigate or reduce the impact, respond to that impact of that microbial threat, and also recover from that incident of a microbial threat. So there's a lot of common themes in our National Biodefense Strategy, as there are in preparing the world for emerging threats from nature as well. And we also, you all have seen this a lot of times, but we also want to go back a little bit in time to talk about a goal we have. Our pandemic influenza goal, for example, is to get in front of that epidemic curve with vaccine. In 2006, when we did an assessment in the country, we saw that our best efforts to make enough influenza vaccine for 2 doses to cover everyone in the country is going to be disappointingly way after the pandemic has swept. In 2009, one would argue we were better at that. We had much more capacity to make more vaccines, but we still weren't fast enough to get in front of that curve. In 2018, we have enough capacity in our country to make over 700 or 800 million doses of pandemic influenza vaccine. Our challenge still is knowing when to use it, where to use it, how to get it out, and how to administer it as quickly as it can now be produced. So our goal for influenza and our goal for any of these threats is to make sure that our vaccine and our countermeasure response is in front of that epidemic curve. We're going to hear a lot about the history over the next couple of days as well, and I don't want to dwell on it other than to show that there have been a number of outbreaks and pandemic events through the last 100 years since 1918. Some of these are extremely devastating in terms of mortality. Some of these are less devastating in terms of mortality. And look at the SARS, 1,000 deaths, but it was still very economically devastating. So there's an imbalance in the morbidity seen from some of the outbreaks and pandemic things that emerge versus the overall economic impact of many of these threats. And we know if we look at the economic impact, SARS, for example, in 2003, 2004, about a $30 to $100 billion economic impact. Ebola in 2014, 2016 was about 10% or more the gross domestic product economic impact in the countries associated with Sierra Leone, Liberia, and Guinea. And looking at the influenza pandemic, of course, 2017 data showed us that an outbreak of influenza doesn't have to be a pandemic outbreak. It can be a very severe seasonal outbreak of influenza, can have a tremendous macroeconomic impact on our country and on the world. And I want to go to a recent publication from our National Academy of Medicine. The Commission on Global Health Risk Framework said in 2016 the average economic impact of global outbreaks going forward is going to be about $60 billion per year. And another 2016 report looking at the emergence of antimicrobial resistance and unmitigated by 2050, this could be a $100 trillion cost of an emergence of antimicrobial resistant bacteria. And many of you have been involved in the discussions about Disease X. So I talked a lot about the things we know about and can predict and we see little glimmers of, but there are still hundreds of thousands of additional organisms out there that are circulating that we know about already that could emerge and cause total devastation in terms of morbidity, mortality, economic loss. So we have to look at the common elements. How do we get in front of those outbreaks? Many things are very technical and detailed. You can spend several days or weeks or years talking about the biggest impact you would have in an outbreak response. But we like to break it down to some of the most simple, basic elements. Early detection matters. If we don't know what's come our way until it's too late, every day counts. That organism is spreading somewhere else, either locally, regionally, nationally, or globally. Vaccination absolutely matters as well. Behavioral countermeasures matter significantly. And it's knowing when and where to use those behavioral countermeasures effectively. And we still have significant gaps in host-based treatment options. Understanding immune modulation, understanding cytokine storm, understanding common elements that our body is triggered in our body when we're exposed to bacteria or viral organisms. This was a recent simulation funded by the Gates Foundation for the Institute for Disease Modeling. I'm sure many of you have seen this. This was recently presented by Bill Gates himself. I just want to illustrate for a pandemic outbreak similar to the 1918 influenza, how quickly the death toll mounts. If you look at 3 months into this pandemic outbreak, over 10 million people have already died around the world. 4 months when our best efforts today to make a pandemic influenza vaccine could start coming out of the factories, you have 22 million people dead. 6 months into that pandemic when our best efforts for a vaccine are now available, 33 million people have died. It tells you the importance of time and speed and early detection and warning systems and the desperate need for new technologies to address this outbreak. So in BARDA, we have developed an agent-based model created by a number of our modelers to represent an unmitigated pandemic of comparable transmissibility to that global simulation I showed you funded by the Gates Foundation. However, this model focuses on the United States, and more specifically, it's a simulation of the DC, Maryland, and Virginia area. It represents transition of influenza between people in these regions, and each person is represented uniquely in the simulation by an agent. The agent has multiple mixing groups, home, work, school, and general contacts wherein transmission can occur. And the specific risk of transmission in these various settings vary by age group and are calibrated to the results of the influenza transmission contact studies. I had to read that from the modelers. They put a lot of work into this. They've been working on this for about 4 years. It's a very specific agent-based model that's trying to simulate as much as possible, not just a magical force that says, here's what will happen if you introduce vaccine into the world or drug into the world. But here's what will happen among individuals who interact in a pandemic, and as they become aware of the pandemic or the infection outbreak, and allowing them to take behavioral actions that will impact their transmission and the further transmission of that pandemic. So this curve just represents the epidemic curve, very similar to the map we just showed from the other institute. Our goal then in BARDA is to look for ways to change that curve and decide where we can go by 2030, where we can have the greatest impact in flattening that curve and pushing that curve outward so we have the time necessary to make a vaccine. Global collaboration is absolutely essential for early detection, Data sharing, knowledge sharing, sample sharing, all of those are absolutely critical in getting in front of an outbreak curve. We also have to empower individuals. We cannot sit as government entities and continue to just brief out instructions without giving people tools to do their own intervention, take responsible actions, and get treated sooner. We also have to invest in the rapid, nimble production platforms for vaccines and medical countermeasures. So we looked at our model at a layered mitigation using future technologies, looking at in-home diagnostics and wearable indicators to enable earlier disease detection by an individual and encourage them to take earlier reaction to get treatment sooner. We also targeted implementation of non-pharmaceutical intervention measures and looked at the impact of rapid vaccine and vaccination systems. So imagine if you were sitting at home and you had a technology in your home that told you pre-symptomatically that you were exposed to something such as influenza. That information was augmented by information and messages in your global community on the news coming from your public health entities saying that there is a pandemic or an outbreak of something in the community. That information is shared with your healthcare provider through our current capabilities of telemedicine so they can get the additional information and make a prescription for an influenza antiviral. And that antiviral can now be delivered by curbside drop-off or drone delivery. These are not futuristic technologies. This is what's used today. All of this enables you to get treated sooner and to stay home to reduce the further transmission of that virus. So we took those interventions into the model. We saw the impact of an unmitigated response and then the early antiviral use by giving those individual agents that information sooner and allowing them to interact and get treatment sooner. We then took it to the next level. We looked at the non-pharmaceutical intervention. So we all know from various studies the impact of hand hygiene, the impact of respiratory protection, staying at home, closing schools. All of those studies are done at different levels, individually in isolation. Some of us believe one has more impact or less impact than the others. We just put them all together saying an individual has a number of options. Regardless of the option they take, they're going to take responsible action to try to reduce the spread and impact and further transmission of that organism. So we modeled this in this agent-based model. We saw the synergistic impact of the, I'll show you here, of the early treatment alone and then the early treatment along with the non-pharmaceutical intervention. So significant flattening and pushing out of that epidemic curve. And if this is our notional line for vaccine, at our best efforts today, vaccine delivery, you see that now you have bought time for vaccine to be available and vaccine to begin having an impact on those individuals being exposed. So then we looked at the vaccine technologies. There's a lot of energy today in the vaccine technologies, making the vaccine production faster using recombinant-based technologies, looking at new ways for distribution of those vaccines. Vaccine alone in a factory, in a vial, in a tank, in a bag doesn't do anyone any good. We have to continue investing in the technologies that make that vaccine available, make sure that we have distribution channels so it's out in the community and that it can be administered easily and rapidly to be able to elicit the immune response necessary for an outbreak. So there's a lot of room for improvement in our vaccine technologies, and there's a lot of energy around developing each of these technologies today. So when we put that in the model, you can see now if you have the early antiviral treatment based on early detection and notification in the home, couple that with non-pharmaceutical interventions, and now you couple that with a vaccine that comes out even on this time course, you can see the dramatic impact it has on flattening that outbreak curve. I want to go back, though, just one step to say, what if I just had vaccine alone? If I had vaccine alone with our current technologies, vaccine alone makes a slight impact, but not a big impact at all. It's very important then to have this layered effect in a controlled, coordinated way globally to show the true impact of early antiviral use combined with non-pharmaceutical intervention, combined with an effective vaccine. And it's also important to think about an end-to-end solution. So Every one of these areas has a lot of research happening. There's companies working in these areas. There's a lot of basic research. How do we develop technologies for early awareness or home detection? How do I change how I manufacture drugs or vaccines? How do I distribute those drugs or vaccines? How do I identify if this vaccine is going to work or the antiviral drug is going to work or not? There's a lot of work that's been done in isolation. Each of these areas is ripe for technology innovation. However, the technology innovation alone, a lesson learned that we have is innovation alone doesn't do any good at all. We can make a faster way to make a vaccine, but if it's not tied into a faster, earlier notification system, if it's not tied into easier distribution channels and administration systems, the innovation in that vaccine doesn't benefit us at all. If we invest in early detection, and we don't tie it to using that information to make the vaccines or drugs sooner, none of these in isolation work. We have to incorporate every single component of technology into an end-to-end solution from early situational awareness all the way to the administration of the medical countermeasure. And also it's very important that technology alone does not solve the crises. In addition to the technology, we must have strong leadership. Global leadership, regional, local, national leadership, all the way down to the individual community, and even within the family. We must build and make the technology available in the context of national healthcare systems and regional and local healthcare systems that are prepared for a response, are exercised for that response, and have the support for that response. And it's important to realize that everything we do is connected. I think this echoes some of the comments that KG made in the opening as well. One family, one community, one nation, one country alone cannot do this. We must do this in harmony globally. The global collaboration, sharing of knowledge and information is probably the most important aspect of any pandemic outbreak and response. We also must simplify and regionalize medical countermeasure production. One large factory in one corner of the world is not going to solve our problem. We need to shift scaling up to scaling out. It's critical that nations have access to vaccines around the world. We cannot stop a pandemic in one country alone. So we have to think about that when we build the capacity to manufacture vaccines or drugs or diagnostics or any medical countermeasure. We cannot forget the impact of local community hospital preparedness and how that ties in a global mechanism. Each country cannot have a unique preparedness response posture. Again, this is where the global coordination and alignment and collaboration is absolutely critical, because it's important that we do this all at once around the world during the pandemic. And we have to exercise that. And I know even in our country, it's been a long while since we've had a real test of failure exercise of our pandemic response capabilities. And a lot has changed. It's time that we put together the plan and exercise. And then the bridge that we're trying to push a little bit farther at BARDA and in ASPR is to empower the individual. No longer should the individual have to sit at home and wait for the government to come help them or rescue them or inform them. There are tools that we can give to individuals today. It's information, it's home diagnostics or indicators, it's tethering to a healthcare system from home. It is the information in advance of an outbreak and what they can do to reduce the risk to their family and their community. These tools to empower the individual will have one of the greatest impacts in slowing and flattening and pushing out that curve. So as we invest in the large-scale infrastructure, we invest in meetings and collaboration around the world at the highest levels of the government and down to the states and the communities, we have to invest just as much in making sure each individual knows their role in a pandemic outbreak or an emerging disease. So I will leave it there and look forward to next 2 days of conversation. Thank you.